So he is DMRD and DNP in radiodiagnosis. He has been having an experience of 13 years in radiology, and he has been associated with Fortis Escorts Hospital, CK Birla Hospital, and at present he is working as a senior consultant radiologist at BMC HRC. And he has got a keen interest in the cross-sectional imaging like CT and MRI. And I'm sure all of you will be having really a great learning session with him. So we welcome you, sir, and over to you.
Thanks a lot. Am I audible?
Yes, you are very much audible.
First of all, I would like to thank Dr. Kanchan for introducing me so well, and also thanks to invite me for such lecture. Can we start with the lecture?
Yeah, sure, sir. You can share your screen.
Is my screen is visible to all?
Not yet, sir, because you haven't shared your screen. You can share your screen. You press on the share screen icon, sir.
Yeah, just a minute.
Yeah, sure.
Now is it visible?
Yes, definitely, sir. You can make it a slideshow. Yes, over to you, sir.
Hello, everyone. Good evening. Today we will discuss about MR interpretation of LS spine. Magnetic resonance imaging has revolutionized imaging of spine and is now the gold standard imaging in most of spinal pathologies. It has replaced the conventional modalities like X-rays, myelography, CT myelography in spine evaluation. The intervertebral disc, vertebrae, ligaments, spinal canal, and neural foramina may all be evaluated using current MRI techniques. Just coming to the basic anatomy of the human spine is composed of 33 vertebrae arranged in a column and connected by ligaments, muscles, and intervertebral discs. The vertebrae are grouped into 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal segments. In the adult, the sacral and coccygeal segments unite with each other to form the sacrum and coccyx. For evaluation of LS spine, scanning is done in following planes: sagittal sections in T1 and T2 weighted images, coronal stir images, axial T1 and T2 weighted images, and then myelogram. In MRI, not only the sequence, but also the plane in which we are getting the sequences are also very important. By one, we will see what to be seen in sagittal section, what to be seen in coronal section, what to be seen in axial section. So each and every plane and each and every sequence has its utility especially. First of all, we will start the sagittal planes. This is sagittal T1 weighted images, and this is sagittal T2 weighted image. So whenever you see a MRI LS spine, the sagittal images, what are the things you should look for? First of all, just like one X-ray, first of all, you need to see the vertebral body height in the sagittal images. You can see this square-shaped vertebra, which is slightly concave anteriorly. Okay, you can see the vertebral body height are symmetrical, and in between the vertebra, you can see this is the intervertebral disc. So not only you can see the intervertebral disc height, which is normal, which is symmetrical in all levels, but also the central hyperintensity on T2 weighted images, which is considering a normal nucleus pulposus. So first of all, vertebral body height, second intervertebral disc height, its signal, then the other thing.
I would request all the participants to keep yourself muted. Something Samsung SM, please keep yours. Okay, sir, I'm doing one thing. I'm muting everyone. You can unmute yourself.
Should I continue?
Yeah, sure, sir.
The other things which we should look for in sagittal images are the prevertebral section. This prevertebral area will tell us about any prevertebral collection, any lymph nodes can be there, there may be aortic aneurysms or anything else we can see in this area which can be better seen on this sagittal images. Except this, any listhesis either anteriorly, posteriorly, they can be visualized on the MRI sagittal images very well. Then this part behind the vertebra is the lumbar canal, lumbosacral canal. The central intensity is the vertebral spinal cord, and this conical part is conus medullaris, usually terminates at L1-2 level. Surrounding by this is the CSF signal intensity, which is black on T1 weighted images and white on T2 weighted images. Commonly, we call it hypo-intense and hyper-intense on T1 images respectively. So this is the thecal sac in which we have CSF. Within the CSF, we have cord, and outside this thecal sac, we have extradural fat, which is appearing hyper-intense on both T1 and T2 weighted images. Behind that, we have spinous processes, we can see, and between them, we have interspinous ligaments. Basically, we will discuss the normal appearance, normal things, what we can see on T1 and T2 weighted images in detail later on this presentation. Main concern at this slide is what to be seen on sagittal images. Now, the basic implication of coronal stir images, which is taken as a protocol in all the MRI LS spine, is to visualize these psoas major muscles. Not only you can see the vertebral body heights, intervertebral disc, but the main implication of coronal images is to see these psoas major muscle. Many a times we can have paravertebral abscesses, including this psoas major. So patient can have low back pain without any involvement of spine, but the psoas abscess may be the cause. One other important thing is this kidneys. Both the kidneys can be visualized in this coronal section. So sometimes gross hydronephrosis or any pathology related to kidneys, they can be marked out on this coronal section, which can also be a cause of back pain. The other important implication of coronal images is bilateral SI joints. We can see this is the sacral ala, this is ilium. So these are both symmetrical SI joints, which are absolutely normal. Many a times when the patient got MRI LS spine done for the backache, the spine, LS spine is absolutely fine. There is no disc protrusion, no disc bulge, no collapse, but the sacroiliitis is present, or the edema around the sacrum can be present. So this extra finding can be obtained only by this coronal stir images. Axial images, you can see this is the axial section through the disc. So this is the disc. Central part is known as nucleus pulposus, and the peripheral collagenous part is known as annulus fibrosus. So in axial images, what to be seen? First of all, we can see aorta, IVC, prevertebral region very well. Any collection here, any lymph node there, any change in the diameter of aorta or IVC, we can very well seen on the axial images. Then the second important thing we should see in axial images is paravertebral muscles. These are two psoas major muscles. So any pathology related to psoas major, these are quadratus lumboris muscle. These are erector spinae, multifidus. So posterior paraspinal and paraspinal muscles, they can be very well visualized on the axial section, and we should look for them while we are visualizing the axial sections of MRI. Then we can see the lumbar canal. The lumbar canal is triangular in shape, in which we can see this round structure is the thecal sac. And these dots are actually the nerve roots. The sacral nerve roots are situated posteriorly, and lumbar nerve roots are situated anterolaterally. These are the neural foramina, which we can see through which the nerve roots are exiting. So these all things, like other things, are neural foramina. You can very well seen on the axial images only. These are the this is superior articular facet. This is inferior articular facet. This is the lamina transverse spinous process. So the entire anatomy which we just discussed, which can better be seen on the axial images. Now we will discuss what is the normal appearance of the MRI LS spine. Just again starting, this is T1, this is T2, sagittal images. Just we will focus that on T1, vertebral body appears slightly hyper intense to muscles. So in the intervertebral muscles, in relation to this, vertebral body appear hyper intense on T1 weighted images because of presence of yellow bone marrow. And on T2 weighted images, it is slightly intermediate signal intensity, less than the T1 weighted. Because of the fact, T1, it will appear hyper intense. In between the vertebral body, you can see this is intervertebral disc. This intervertebral disc has three components. First, nucleus pulposus, which is appearing hyper intense in centrally. Then peripherally, we have annulus fibrosus. And on both the sides, we have end plates. So the vertebral body, intervertebral disc. Then anteriorly, we can see thin linear structure. This is known as anterior longitudinal ligament, ALL. And then posteriorly, we can have posterior longitudinal ligament. Okay. Vertebral body, disc, anterior posterior ligament. This we have already discussed. This is the spinal cord surrounded by a thecal sac, and outside that, this is extradural fat. This is the cord which is terminating here as a conus medullaris, and these are the nerve roots will form the cauda equina. These are the nerve roots which have already exited from the cord, and this is the thecal sac. The termination of thecal sac we see in this scheme. Then posteriorly, we have already spinous process. In between the spinous process, we have interspinous ligaments. So these are the things. On T1, usually we see for the vertebral body signal intensity. In the presentation, we will discuss like in metastasis or something. They are very well visualized on the T1 weighted images rather than T2 images. And for any pathology of this, we should look for T2 weighted images, because we can see the contrast of nucleus pulposus and the annulus fibrosis and the end plates is very well visualized on T2 weighted in comparison to T1 weighted images. These are actually the mid-sagittal sections which are showing these normal structures. When we go slightly laterally, we can see this is the pedicle of the vertebral body. And from the pedicle, we can see this part is known as pars interarticularis. Like in this vertebra, this is pedicle. This is pars interarticularis. Superiorly, this is superior articular facet, which is forming the apophyseal joint. And again, inferiorly, this is inferior articular facet, which is forming the facet joint. Axial images, we can see this is the pedicle, vertebral body, aorta, IVC, and the bilateral paraspinal muscles. On axial images, the facet joint has a mushroom-shaped appearance. You can see very well how beautifully we can see the facet joint in the axial images. This is superior articular facet. This is inferior articular facet. This is the joint space, and this is lamina of the vertebral body. So it is giving a mushroom-shaped appearance of the facet joint. Now we will discuss the intervertebral disc. As we have already discussed, it has three parts: central nucleus pulposus, peripheral annulus fibrosus, and the outermost cartilaginous end plates, superior and inferior end plates. This is annulus fibrosus. This is nucleus pulposus. Contour of intervertebral disc and vertebra. Usually intervertebral disc has posterior concavity. But as we go down at L4-5 or L5-7 level, it usually becomes convex. And this is absolutely normal. Many of the time we think that it should be concave, and if there is a convexity, it should be some protrusion of the disc. But it's not like that. At L4-5 and L5-S1, the normal disc is usually slightly convex posteriorly. Now we will discuss some age-related changes in the intervertebral discs. With aging, the intervertebral disc changes in appearance and collagen increases. These changes result in a lower affinity of the disc for water and therefore a decrease in the water content of the disc. The water content of the disc may diminish by 10% or 15% over 5 decades. Therefore, with aging, the signal intensity of the disc diminishes by a few percent. Loss of the normal high signal intensity, which we have seen on T2 weighted images, or loss of this normal intervertebral disc height suggests degenerative changes within the disc. Here we can see this is the LS spine in an adult male. So we can see the central hyperintensity on T2 weighted images and the height of the intervertebral disc. But in this aged patient, elder patient, we can see not only the height has been reduced, but also this hyperintense signal has also been lost. So we say it either dehydrated, degenerated disc because of the age-related loss of fluid content. Coming to modic end plate changes, modic end plate changes represent a classification for vertebral body end plate MRI signal changes. Type 1, type 2, and type 3, there are 3 types. First, represent bone marrow edema. So any edema in any part of the body will appear hypointense on T1 and hyperintense on T2 with enhancement on the gadolinium contrast. Type 2 actually represent the fatty signal. So they will appear both hyperintense on T1 and T2 weighted images. Type 3 represent sclerosis. So it will appear hypointense on both the sequences. Here we can see this is a T1 weighted images. How can we identify? Just by looking at the CSF. If the CSF is black, it is a T1 weighted images. So on this T1 weighted images, we can see these are the fatty marrow, T1 hyperintense means it must be fat, either in sclerosis or in fluid. It must be hypointense on T1 weighted images. So if we can see these end plates are irregular with fatty marrow signal intensity on both the sides, this is known as type 2 modic changes. Here we can see on T1 weighted images, we can see irregularity of the end plate, reduced disc height with hypointense signal on T1 weighted images and hyperintense signal on T2 weighted images, suggestive of edematous changes, type 1 modic changes. Coming to the ligaments, this is a schematic diagram as I have already discussed. This is the anterior longitudinal ligament. Because of this, this is a concavity in the anterior aspect of the vertebral body. When it got thickened, there will be squaring of the vertebra, commonly seen in ankylosing spondylitis. Posteriorly, we can see this is the posterior longitudinal ligament. Usually in cervical spine, we see OPLL, ossified, thickened posterior longitudinal ligament, which is not commonly seen in LS spine. Then other ligaments are in between the spinous process. We have these interspinous ligament. The next most important ligament, ligamentum flavum, which is at this location, just medial to the lamina, which is best seen on axial images. Now we can see this is the axial images. This thin line of hypointensity on both the T1 and T2 weighted images represent ligamentum flavum. So to look anterior and posterior longitudinal ligament, interspinous ligament, supraspinous ligament, you should look for sagittal images. And to comment on facetal arthropathy or ligamentum flavum arthropathy or hypertrophy, you need to see the axial images. Spinal canal diameter, usually cervical at level of C12, it is 15 millimeter. Lower cervical, it's 12 millimeter. And dorsal spine is 12 to 13. But as we are discussing at present, lumbosacral spine, usually the vertebral canal measures 15 to 20 millimeter in AP diameter in lumbosacral region. Anything which is less than 11.5 millimeter is considered abnormal. Lateral recess, or it is a space or gutter which is bordered laterally by the pedicle, anteriorly by the posterior aspect of vertebral body, posteriorly by the superior articular facet, and medially there is a thecal sac. This space which contains traversing nerve root is known as lateral recess. And it is, if less than 4 millimeter, we consider it's a lateral canal stenosis. Spinal cord on cross section appear elliptical in case of cervical spine. It is rounded in thoracic spine and diamond shape in conus at the level of conus medullaris. Normal conus medullaris in adults ends at L12 level. There is centrally placed gray matter and peripheral white matter. The gray matter have H-shaped configuration. Central gray matter volume relatively increased in cervical and lumbar region. Here we can see on the T1 and T2 weighted images, this black thing is actually representing the CSF, which is within the thecal sac, and within this thecal sac, we can see the cord. So this is the cord and this is the thecal sac. Here we can see the nerve roots exiting from the cord, the ventral and the dorsal rami of the nerves. The spinal nerves and their accompanying blood vessels enter and exit the vertebral canal through the intervertebral foramina or nerve roots canals. The boundaries of the intervertebral foramina consist of the pedicles above and below, the articular processes and apophyseal joints dorsally, and the intervertebral discs ventrally. Here we can see these are the neural foramina through which the nerve roots will come outside. As we can see in the superior aspect, just behind the vertebral body, they are wider than inferior aspect. So it's a typical keyhole appearance. And the point to be noted, nerve root will come outside from the superior aspect of the neural foramina. So many a times when there is a small protrusion of disc, but there will be no compression of nerve root at all because of its location placed superiorly in a case of neural foramen. Here we will discuss the concept of exiting and traversing nerve roots. Look like a vertebra at the level of L4. Whatever nerve root will come outside through the neural foramina is actually L4 exiting nerve root. These are the nerve roots which are within the thecal sac at present, but gradually they will come out and will remain within the vertebral canal, though they are known as traversing nerve roots. These traversing nerve roots are actually at the level of L4. Whatever nerve root will come outside, that is L4 exiting, and which has just come outside from thecal sac is traversing L5 nerve root. this will remain traverse like this and come outside at the level of L5. So at L5, we will say it L5 exiting nerve root. Here we can see both the roots. Through the neural foramina, we can see the exiting of this exiting nerve root. And here, outside the thecal sac within the spinal canal, we can see the traversing nerve root. The traversing nerve roots are exactly located in the level of lateral races, which we have just discussed. The lower spinal nerve root exits the conus medullaris and passes inferiorly within thecal sac, forming the cauda equina. On axial section, the root of phylum terminale typically lies in symmetrical crescent-shaped pattern with lower sacral roots positioned dorsally and lumbar roots positioned anterolaterally. This we have seen like spinal cord with conus medullaris, cauda equina, and the thecal sac. This entire anatomy we have already discussed in this presentation. These are the nerve roots very well seen on the myelogram. Here we can see this is the thecal sac having multiple nerve roots, the part of cauda equina actually. So the posteriorly these dots are sacral nerve roots and anterolaterally these are lumbar nerve roots. Sacral plexus is formed by ventral rami of L4-5 and S1 to S4 nerves. Medial to psoas, L4-5 nerves join to form lumbosacral trunk. After they exit the spine, S1 to S4 nerves converge in front of piriformis muscle and join with lumbosacral trunk to form sacral plexus. The sciatic nerve, the nerve roots are L4 to S3, is the continuation of sacral plexus only. These are thecal sac myelograms, which are not much useful nowadays because of extensive evolution of T1, T2, axial, coronal. But sometimes a prominent disc bulge can very well seen directly on the myelogram, and we can see there is a stenosis of canal and there is a compression of the thecal sac. Other utilities, sometimes a tiny perineural cyst or the arachnoid cyst can be very well seen along the bilateral exiting nerve roots from cord. Till this moment, we have discussed the normal appearance and normal MRI things in the MRI LS spine. Now we will see what can be some common pathologies in the LS spine. So we will discuss only few of them like disc herniation, vertebral collapse, metastasis, and pot spine. Just a small slide to discuss the disc herniation. The abnormal disc bulge, abnormal lumbar disc can be divided into two parts. If only more than 25% of the disc circumference is involved, it means if the protrusion or the bulge of the disc is diffuse, it is considered as a bulge of a disc, not protrusion or extrusion. When it is less than 25% of the circumference, like this is the entire circumference. When the protruded or the bulge part is within 25% of the entire circumference, it is known as herniation. Okay, when it is more than 25%, either we can say a diffuse form of the herniation, which is called as bulge. Bulge may be symmetric or asymmetrical. You can see in the images. The herniation can be divided into protrusion and extrusion based on relationship between base and dome. This is the base of the herniated disc and this is the dome of the herniated disc. With base is larger than the dome, it is known as protrusion of the disc. When the base is smaller and the dome is larger, it is known as extrusion of the disc. The other thing is sequestration, in which this herniated disc will get separated from the parent disc and it will be either cranially and caudally migrated. Here in this LS spine, we can see these are the desiccated, dehydrated L34, 45 and L5S1 disc. And here we can see there is a protrusion of the disc. And where is it? In the axial image, we can very well see it is within the lateral recess compressing the traversing nerve root. This is the normal traversing nerve root on right side, but on left side, we are not able to visualize it. Because of this protruded disc, which is left posterolaterally within the lateral recess, there is a compression of traversing nerve root. Then other pathologies, vertebral collapse, we can see very well in the sagittal section. These vertebrae have maintained their height, but there is an anterior wedging of this vertebra, but there is no edema. So it signifies it must be an old collapse. But on this vertebra, we can see bone marrow edema within and break in the superior end plate with reduced height. So this may be an acute or a recent injury or traumatic case of spinal trauma. Other case, metastasis, as I have told you, very well visualized on the T1 weighted images. These are T1 weighted images with CSF black. We can see very well T8, T9, L1, hypointense lesions which are protruding within the spinal canal. They can be seen. Multiple vertebrae are involved. So this was the case of a metastasis. Pot spine or the TB of the spine is also very commonly seen as a lower backache patient. We can see there is a contiguous involvement of these two vertebra, L2 and L3, with the intervertebral disc has also been involved, end plates had been eroded, and with the large prevertebral as well as ventral epidural abscesses has been formed. The edema can also be seen in the L2 and L3 vertebrae. It is a case of Pott's spine. On concluding this session, MRI is most useful imaging modality for spine and now is gold standard in imaging most of the spinal pathologies. It has replaced conventional modalities like X-rays, myelography, and CT myelography. By knowing the correct anatomy of the intervertebral disc, vertebrae, ligaments, spinal canal, and neural foramen may all be well evaluated using current MRI techniques. Thank you.
Thank you so much, sir, for such a phenomenal presentation. I hope everybody enjoyed it thoroughly. Now we are just open for questions. Anybody, if you have any question, you can ask us. Sir, you can stop sharing the screen.
Yeah.
Thank you. So any questions from anyone? I hope all the pain physicians here, they must be wondering. It was so to the basics and it has covered everything. So thank you so much, sir. I really thoroughly enjoyed your presentation. So Dr. Tambi wants to ask something. Yes, you can unmute yourself and you can ask. Yes, Dr. Tambi. Okay, I think I need to allow you to unmute yourself. Yes. Yes, Dr. Tambe, you can ask. Yes.
Madam, can we get the slideshow presentation?
Slideshow. I think you can watch the recording in our YouTube channel many a times. Isn't it?
Okay.
Same thing will
is it there in recording?
Yeah, we will be just sharing it. Don't worry, in the YouTube channel. Okay. So there's a question for you, sir, from Dr. Kritika.
One more question, ma'am.
Yes.
Most of the times, the MRI findings they do not correlate with the symptoms of the patients. So, can he elaborate more on that?
So, Dr. Madhur, would you like to say something?
Definitely, in all the cases, we cannot consider or we cannot expect that MRI will solve all the questions of the patient, because the pain of the patient may not be because of lumbosacral pathologies only. As I have discussed in the MRI, many of time patient with MRI LS spine may have low backache, but the cause may be a renal calculus or maybe some ovarian pathology or some abdominal pathology. And in such a cases, when MRI will say some protrusion, excision, they are just a coincidental finding. So these findings are not correlating. They are not explaining the pain of the patient because that is not the cause of the pain of the patient. So we need to understand that MRI LS spine can tell you only about the MRI pathologies, the LS spine pathologies. You cannot see all the other pathologies if you are not getting it that with the clinician, with the clinical features, the MRI findings are not correlating. Then I advise you to get further more investigation, like to ultrasonography to see the calculi, ovaries, uterus, and other pathologies should be ruled out.
So the gist of the story is you need to have a proper clinical diagnosis, and that should be confirmed by your investigation. It is not the vice versa that you are seeing an image and you are treating the patient. So you are supposed to treat the patient, not the image. That's what is the gist of the story. I hope you got your answer.
Yes, thank you.
So fine. Now we have second question, sir, for you. Is SI joint pathology well made out by MRI sensitivity and specificity? So this question is by Dr. Kritika.
Yeah. Definitely the best investigation for SI joint evaluation is MRI. In MRI LS spine, usually we take coronal section just to screen them, whether to see they are absolutely normal or some kind of pathologies or altered signal intensities are there. If on LS spine screening we have mentioned there's some altered signal intensity or fluid or some erosion is there, we should get a proper MRI SI joint should be done with or without contrast. In MRI SI joint, earliest changes of bone marrow edema, Then thereafter erosion, joint space involvement, collection, they can be very, very well seen on the MRI, and no other investigation, no other imaging modality can elaborate the features as good as MRI. So MRI is the investigation of choice if you are suspecting any pathology related to the SI joints.
Excuse me, madam. I just want to confirm the role of the diagnostic blocks then. If MRI can pick out every SI joint pathology and even facet joint pathology for that matter. So then when do you proceed with the diagnostic block for those patients presenting with paramedian pain, low back pain, and clinical symptoms suggestive of SI joint pain?
So I would give this question to our chairperson because he is wanting to speak on it. So Dr. Chinmoy, you can just carry on with this question.
See, as far as I understand, MRI is showing you the anatomy. Pain is the product of physiological change. So you will see the compression, you will see the change. That doesn't mean that action potential is generating from there and you are perceiving pain. Anatomy and physiology may not go together hand in hand. So MRI will say that yes, there is facet joint arthritis or there is SI joint arthritis. But that arthritis, you know, but it doesn't mean that it is giving you the diagnosis that, okay, this much of pain is coming from this joint. There may be a 5 facet joint problem, pain may be coming from 1 facet joint. Then to separate this, you need diagnostic block.
I hope you got your answer. Okay. So, sir, there is one more question for you. What is the basic difference between plain and contrast MRI?
So for most of the pathologies, when we are talking about low back pain, a plain MRI LS spine is sufficient. All the maximum pathologies like protrusion, extrusion, or any other pathologies related to vertebral body edema, vertebral body reduced height, disc desiccation, disc fracture, they all can be very well seen in a plain MRI. There is no need of contrast for that. The reason is because MRI has its inherent contrast on T1 and T2 weighted images. So all the structures can be very well seen separately, even on the plane scale. The role of contrast usually starts with when we are suspecting some mitotic or a neoplastic pathology to differentiate a hematoma from a malignancy or to see the extent of the things. In case of sometime we are suspecting arachnoiditis or the neuritis. In such a cases, enhancement is important, but these are very, very less number of cases. So I advise you, first of all, in any cases of backache, a plain MRI LS spine should be asked to done. And if it is unconclusive or in some of the things which are in favor of that, we need contrast for that. That should depend on the width of the radiologist. That can be discussed thereafter. And then only we should proceed for the contrast. Directly contrast MRI LS spine has no role, I don't think.
One question to Dr. Madhur from my side. Is there any fixed protocol throughout India to print the MRI plates? Because when I get it, I find it different in different areas.
Look, as in the presentation I discussed, there are particular sections in particular sequences which should be taken as a policy, as a protocol, like sagittal T1 and T2 weighted images, coronal star images, axial T1 and T2 weighted images, and myelogram. But that totally depends on the particular center of the comfort of the radiologist as well as the clinician who is demanding the MRI LS spine. So there is actually a comfort between both of the clinician as a radiologist. They decide both of what are the things they need on the film, because we took all the sections and whatever you will ask, we can provide on the film. But as in general, you are asking me what is the protocol? The protocol is providing T1 and T2 weighted sagittal images, coronal star images, and T1 and T2 axial images. This is a protocol to be given in each and every case.
Oh, thank you.
So one more question for you, sir. Can you please explain how to make lumbar? I think she wants to ask lumbar canal stenosis. So this is from Dr. RR. Since you have not written your name, so I cannot pronounce it. So what exactly you want to ask if you are there, Dr. RR? You have written, please explain how to make lumbar canal stenosis. Do you want to know what exactly should be the parameters to call it a lumbar canal stenosis? The AP diameters?
Yeah, yes, ma'am.
Okay. So, sir, can you please throw some light on that?
Yeah. Actually, as I mentioned on the presentation, that the anteroposterior diameter of the lumbar canal is usually 15 to 20 millimeter. If it is less than 11.5 millimeter, or in the cross-sectional area, it is less than 120 millimeter square, it is considered as a lumbar canal stenosis. Otherwise, for mild, moderate, severe, these are the subjective things, depends on the how much protrusion or extrusion is there. But if it is less than 11.5 millimeter in AP diameter and 120 millimeter in cross section, we consider it as a canal stenosis.
One more question for you, sir. Is lateral recess and neural foramen similar?
No, not at all. Lateral recess boundaries we just discussed. In the lateral recess, anteriorly there is the vertebral body itself. Posteriorly, there are superior articular facet. Medially, it is open to the thecal sac, and laterally we have neural foramen. So you can consider whatever structure, whatever space which is just medial to the pedicle of vertebral body is known as lateral recess. And in the lateral recess, what happens? It consists of traversing nerve root.
I hope you got your answer. And in the meantime, I would request all of you to keep yourself muted, please, because when we discuss things, there are so much of noise which is coming from the background. Please keep yourself muted.
Sir, can you please little elaborate on T1, T2 weighted images? Although Chinmoy sir has taught us, but from your side.
Yeah. Look, T1 and T2, first of all, you need to see how you can see the lumbar canal. If it is black, in layman language, I can say, if it is black, then it's T1 weighted images because CSF or fluid appears black on T1 weighted images. But if it is bright, it is hyper intense, then you can say it's a T2 weighted images. So first of all, you should look at the lumbar canal. In the lumbar canal, if the CSF is visualizing hypo intense, it's a T1 weighted images. If hyper intense, it's a T2 weighted images. Then the other thing we should look for the intervertebral disc. The central part of intervertebral disc, which is made up of nucleus pulposus, which appear hyper intense on T2. So it will appear white on T2 weighted images, but on T1 weighted images, we cannot differentiate between nucleus pulposus, annulus fibrosis, and these different segments are not very clearly visualized on T1 weighted images. And third, the vertebral body itself. Vertebral body will appear white or hyper intense on T1 weighted images because of yellow bone marrow. On T2 weighted images, they are slightly less white, or we can say intermediate signal intensity. So these are the difference by which you can identify which is T1 and which is T2.
Okay, sir. Dr. Deepak, thank you so much, sir. Sir, Dr. Deepak wants to know when to take fat-free image.
Fat-free, or you can say the fat-suppressed images, the ISTER images. Many of times, like in case of you are...
I would request the participants to keep themselves muted, please. When sir is talking, please keep yourself muted. Otherwise, you will not be able to get your answer. Yes, sir. Sorry. Please go ahead.
Please. Fat-sat images, or we can say fat-suppressed images, which is the other name of STER images, short tau inversion recovery, in which we suppress the fat, and in such a cases, fluid signal intensity will be perpetuated. So any kind of edema, any kind of fluid intensity, if you just want to see, just get the STER images done. In many of cases of trauma, when you do not have a disc, any reduction in the vertebral body height, no direct fracture can be seen. In such a cases, subtle edema can be elicit the feature that there may be a hairline fracture in the STER images. So the utility of STER images or fat set images is to basically to see any fluid suspecting as well as the edema.
I hope, Dr. Deepak, you must have got your answer. So Dr. Ravi Kumar wants to know how to identify listhesis on axial cut section of lumbar spine.
As in sagittal sections, just look at the lumbar canal. If you are having CSF of black color, it means the T1 weighted images. If you are having thecal sac and the CSF is of bright side, it's on T2 weighted images. Just look at the CSF and that will give you the answer whether it's a T1 or a T2 weighted image.
Sir, how to identify listhesis on axial cut section of lumbar spine?
No. As I have already told you that every sequence in every particular plane has its utility. So to see the listhesis, you need to see the sagittal images only. You cannot attempt to diagnose listhesis on axial images. Each plane has its significance. So according to that, you can see that. You need to look for the sagittal images to diagnose the antero or retrolisthesis.
Thank you, sir. Dr. Jyoti wants to know how to see ligament flavum thickening.
Okay. As I have told you, ligament flavum are just inside the lamina of the vertebral bodies. In my presentation, you can see an image in which the thin hypointensity along the lamina. This is ligamentum flavum. And it is more than 3 millimeter in thickness. That is considered as a ligamentum flavum hypertrophy. Anything which is less than 3 millimeter is considered as a normal ligamentum flavum.
Okay. So there is one more question. Is thecal sac compression means cord compression, or can be thecal sac compression without cord compression?
Definitely they are not the synonyms, because the cord will terminate at L12 level, but the thecal sac will terminate at S2 level. So obvious it is at L34 level. If a disc is protruding, definitely there is no cord at this level. So you can have a thecal sac compression or canal stenosis, but no cord compression. Even I would like to say, in LS spine studies, usually most of the cases we can see either thecal sac compression and nerve roots compression, because the cord will terminate itself at L12 level, from where the LS spine will start. So that's a misnomer, or many of the times when the radiologist will write down there is a large disc protrusion, there is a compression, canal stenosis, we consider it's a compression of our cord, but cord has been already ended at L12 level. There is no cord at this level particularly. So whatever compression is there, that is the compression of thecal sac and maybe of nerve roots. So these both are two different things, definitely. Thecal sac compression and cord compression, they are two different things.
They are not the synonyms. That's what. Fine. Yes, sir. Sir, there is somebody who is unmuted. I have been requesting all of you to please keep yourself muted, right? So that we all can hear. How does Dr. Ekta wants to know, how does a facet cyst look like, as it is very common?
Look, facet cyst is a presentation of facetal hypertrophy. We call it as a hypertrophic facetal arthropathy. So in a hypertrophic facetal arthropathy, a cyst will appear as a para-joint cyst. Just beside the joint space, you can have small, tiny foci of hypointensity on T1 and hyperintensity on T2. Just like you can consider it's a fluid. So the fluid will appear hypointense on T1 and hyperintense on T2. So a well-defined cystic structure which is in vicinity to the joint space with the changes in joint, like bulky joint, there will be erosion in the end plates, there will be some fluid within the joint. You can consider it's a facetal arthropathy with parafacetal cyst.
Sir, Dr. Veena wants to know what is the difference between dry and wet facet.
Dry and wet facets are nothing but actually in the degenerative changes, when there will be hypertrophy of the joint, but there will be no fluid. It's a dry hypertrophy, dry arthropathy. But when there is a fluid collection between them, some kind there may be a small cyst formation or the formation of some abscessive form of infective arthropathy, you can have a wet arthropathy. As the name suggests, if there is a fluid, it's wet. If there is no fluid, it's called dry arthropathy.
Okay. Sir, somebody wants to know that are MRI sagittal sections always from left to right?
Pardon?
She has asked, are MRI sagittal sections always from left to right?
Look, this is actually the choice of technician who is printing the film. But usually as a protocol, they are printed from left to right. But I cannot say that all the MRIs you will come across, 100 out of 100 will have the same sequence. Because it's a personal choice, as we have already discussed. The sequences which to be printed on the films, how they are printed, it is totally different in different setups in the different cities in the country. But usually as a protocol, they are printed left to right. But not to be mug up. Just see on the films, you will definitely get some annotation on that.
So can we see neovascularization in MRI as indication of inflammation, root cause of pain?
Look, neovascularization, which signify the neoplasia or some mitotic pathology. In contrast MRI, we can see the vascularization within the tumor. That is actually within the tumor. If the vascularization is there, it's new vascularization. But otherwise, in inflammation of disc or anything else, along nerves, the MRI is not able to visualize that particular vessels.
And Dr. Jiva Priya wants to know, what about the fractures? Should we correlate with CT?
Look, basically for fractures, CT is better than MRI in many senses. First of all, its availability. Very fast we can perform CT scan in comparison to MRI, which will take at least 40 to 45 minutes. And not only the listhesis, fractures, very well fractures. So first approach in case of trauma, as we all know, is CT scan because of its wide spread availability, low cost, as well as very rapid performance of the scan. But if in case of trauma, severe backache is there, there is no fracture can be obtained on the CT scan, then the second step is MRI to see whether there may be a subtle hairline fracture. It can be seen in the T1 weighted images, as well as on star images. We can say no fracture, but significant edema in the vertebral bodies, which can also cause the pain. So the first step is CT scan to see the fracture, and rest, if you are not able to find any fracture on CT scan, just go for MRI to see any hairline fracture or the edema of the bone.
Sir, can you explain about neural foramina and its implication in epidural injection?
Look, neural foramina I can explain. For epidural, you need to consult with some other pain places, as we have all in this forum.
So that we will take care. You explain about the neural foramina.
Neural foramina is actually the part of the vertebra from where the nerve root will come outside. As in my presentation we have discussed, it is a keyhole shaped structure which is wider superiorly and inferiorly it is narrow. And the point to be noted, from this neural foramina, nerve root will arise superiorly, just posterior to the vertebral body, not at the level of disc. So in many of the cases, we will find intraforaminal disc protrusion, but there is no pain at all because the nerve root has been passed superior to that protruded disc. It has not been compressed by the nerve root. Probably you will see the presentation. There is a picture in the presentation. Very well, I have mentioned that. You can understand by that images.
Okay, somebody, I think Akanksha wants to know when to specifically ask for T1 weighted image. I'm also not able to get her. Yes, Akanksha, what exactly you want to know?
Yes, sir. First of all, it's a very nice presentation. Thank you. And sir, I want to know, like you have explained what we look at T2 and T1, like what is more visible and what to note. But like, is there, like if you're suspecting something, when do you specifically concentrate on T1?
Look, these all sequences are the part of a basic protocol of the MRI LS spine. So you need not to mention what sequence you just want to get done. Just write down MRI LS spine. So this is a basic protocol that T1, T2, sagittal, coronal, star, axial, T1, T2. These all images will be provided to you. Nothing to be specified in this particular things.
No, so like we are not ordering, but like we want to specifically see T1 in what cases, like.
Ma'am, sorry to interrupt you. You are not audible clearly.
I think you can be a bit louder. Your voice is very feeble. That's what I think.
Now.
Yes, now. Yes. Go ahead.
So
please.
I was saying, sir, like although we don't order T1 or T2, but if we have, when should we keep in mind to first look at T1? Like that, I was asking. Like what are the conditions?
What are the implications of T1 weighted imaging? So first of all, as I have mentioned, like in case of you are suspecting metastasis in a patient, is a patient of a known case of malignancy, you are suspecting metastasis. So among T1, T2, star images, best images, T1 weighted images. Because the metastases are hypo-intense on T1 and hyper-intense on T2. So the vertebrae which are white, a black lesion, a black metastasis can be very well seen on this. So first of all, in case of metastasis, you should look for that. Second thing, as we have discussed in case of trauma, sometimes we are missing a fracture on CT images because of a hairline fracture. So such hairline thin fractures can be very well seen. Any bony detail, actually I meant to say, in any musculoskeletal MRI, bony details, bony abnormality, they are very well seen on T1 weighted images.
Thank you so much.
There is one more question for you. I think people are very much, enthusiastic to ask you so many questions. Okay, so what about the trigger points in ma'am in practice, can usually palpate muscle knots. Can we see any changes in the muscle in coronal plane or axial plane in case of trigger points? That's what I think she wants to know, that if we are expecting to be it to be a myofascial pain syndrome where we expect some trigger points in the muscle. So can we make it out with trigger points with MRI?
Look, we can see maximum two kinds of changes, either a fatty atrophy, which is commonly seen in case of scoliosis, so one side hypertrophy, one kind atrophy, and second is edema. That is a non-specific finding we can see in many of the cases. So directly comment on the trigger point just by looking at the muscle, it is difficult on MRI.
Okay. Dr. Ravindra wants to know, can we plan a needle trajectory for injections based on MRI?
Come again?
Can we plan a needle trajectory for injections based on MRI?
Definitely, MRI can guide you for many of the procedures, but the main implication is that first of all, you need all the MRI healthy or MRI susceptible instrument for that. And under that, you can definitely do the procedures. But it's costly and it's not suitable in most of the settings.
Much easier is you go for a fluoro-guided or USG.
Definitely.
Yes, of course. Fine. So I think, Ravindra, that is going to be costing too much to you. Okay. So Dr. Shan wants to know, can we differentiate a blood clot in epidural space from tumor mass compressing the cord?
Yeah, definitely. As I mentioned, here we have the utility of contrast images. First of all, usually hematoma, old hematomas just compress. They have mass effect, but no contrast enhancement. But the tumor will definitely have neovascularization, and because of that, that will show the significant contrast enhancement. But yes, many of the cases are there. I would say 10-15% cases in which it is very difficult to differentiate between these two things, because acute and subacute hematomas can also enhance, and some of the tumors are there which are very low grade, which are old, so they will not enhance at all. So not all the cases, but yes, contrast and enhanced MRI scan has significant role to differentiate between a hematoma as well as the tumor. And one other thing to be kept in mind is clinical correlation. If the patient have some bleeding diathesis, a history of trauma, intervention, you can suspect more about a hematoma rather than a malignancy.
I think it's just the same question. Dr. Ravindra wants to know, can we order for MRI for diagnosing excluding iatrogenic epidural hematoma or abscess? I think just
as we have already discussed, this procedures can be very well done by fluoroscopy. Ultrasound guidance is very commonly done for this now. So there is no need to go for MRI for such things.
Okay, so Dr. Rajiv wants to know on PDPH. What exactly do you want to know on PDPH? Dr. Rajiv, are you there?
Yes, ma'am.
Yes, Dr. Rajiv, what exactly you want to know? Don't ask sir what is the management of PDPH. He is not an anesthesiologist.
Yes, ma'am. Asking about the management. Ma'am, can we diagnose? Ma'am, generally we go clinically for the management of PDPH. We go clinically. So, can we diagnose if the CSF is actually leaking?
Okay. So, sir, he wants to know, is it possible to diagnose PDPH with MRI?
What do you mean by PDPH?
Post-dural puncture. Somebody who is keep on talking at the back. I don't know who is. Dr. Rupali, can you please mute yourself?
Yeah. Post.
Okay, I muted.
Where is the chat going? Okay. Post-dural puncture headache, PDPH, no? Dr. Rajiv asked. Yes. Sorry, the chat box went away, so I was just searching for it. I was trying to mute everyone. Yes. Sorry, sir. So it is post-dural puncture headache.
So for headache, you need to go for a MRI brain only, not MRI LS spine. For headache, usually in such a cases, you will have MRI brain, and that is absolutely normal. That is why you make a diagnosis of this. It's a diagnosis of exclusion by radiology. Directly, you will have not any other feature, any positive finding in case of this PDPH.
This question is actually for us.
Yes. Sir, in case of listhesis, is it necessary to take X-ray inflection and extension? because while doing MRI, patient is supine and listhesis may get obliterated. Is it like that? Hello?
Hello?
Sir, he wants to know that if you are seeing a patient of spondylolisthesis, right? So do you need to take an X-ray in the flexion and extension? That's what he wants to know. Is it required?
Look, in case of listhesis, it may be a stable listhesis or it may be a movable listhesis. So to know the stability of this listhesis path, we need to get a flexion and extension. And even the MRI can be done in both the sections. But the cost of MRI will be very high, time will be very high. Just to know the small things of the flexibility or the movability of the two parts, the X-ray will suffice definitely. It will give the answer, X-ray. But MRI can definitely be done in neutral position, flexion and extension to know the mobility between the segments. And that totally govern the management thereafter.
Okay, thank you, sir.
And some of the questions I'm not taking because they are just the repetition of what we have been discussing. So I think it's time to end up. Thank you so much, sir. It was really wonderful. We are very much elated. We are very much thankful to you for this, for giving us time. You know, we all thoroughly enjoyed your session. And thank you so much again. And we are very blessed to have you on board with us.
Very nice presentation. And actually, we will expect that another day you will take another topic.
Thanks a lot. Thanks a lot for your kind words. And I'm also thankful to all of you for giving me this opportunity.
Thank you so much, sir. So it's time to say goodbye to all of you. Thank you to each and every one of you. You all have been very enthusiastic, and I should appreciate today. We had lots of discussion, and that really increases your knowledge, right? So thank you so much to each and every one of you, and hope again we will be meeting up very soon with some new expert from a different field. Thank you so much, everyone. Thank you.